Hello, everyone, and welcome back to our second topic of the week video. And this week, we have all been looking at the topic of ReSPECT forms and DNA CPR discussions. Now, this is quite a heavy topic and a topic that a lot of us are maybe a bit apprehensive about talking about, especially when it comes to those conversations with patients. We might have fears and anxieties about what patients might think, what families might think. So it's probably good for us to spend a few minutes talking through the concerns you have and give some tips about how we could do those conversations better. So before we dive into this topic, we're going to look at the case study that we introduced in our last video, and that should be coming up on screen just now. So we introduced you last time to a 72-year-old man called Terry. Now, Terry, we told you, was normally very fit and active and played golf on a regular basis. He's a retired policeman and he now volunteers at a local charity shop. Sadly, he has recently been diagnosed with metastatic prostate cancer, which has spread to both his liver and his lungs. He has been admitted to hospital today with COVID pneumonia. He is slightly breathless at rest, but he is still fully alert and orientated and able to talk to you at the bedside. You're the medical doctor admitting him, and just before you finish your shift that night, the ward sister has asked if you have established Terry's resus status. So what we wanted to ask you was, what do you do in that situation? Who do you speak to? And what things do you say? It's important to have in the back of your mind that CPR is not guaranteed to bring about success. In fact, it can be quite the opposite. The majority of CPR attempts will be unsuccessful in bringing someone back. So statistics show that only 1 in 5 attempts in hospital are successful at achieving return of spontaneous circulation, or ROSC, as you might hear people on the wards call it. And outside of hospital, it's even less likely to be successful, with only 1 in 10 attempts returning circulation. Now, this doesn't mean that you should never consider keeping an unwell patient for full resus. Not at all. It's right to give people the best emergency care available to them, depending on the patient that you have sitting in front of you. So if you have someone who's relatively healthy at baseline, who's quite active and independent, and who doesn't have very many morbidities, it's absolutely appropriate to keep them for full resuscitation should they go into cardiac or respiratory arrest. And while advanced age in a patient can often mean things like increased frailty and increased number of morbidities or chronic conditions, it's wrong to use age alone as a measure of whether or not somebody should be resuscitated.
So I just wanted to jump in on the last point a little bit for a minute, and just talk about the 1 in 10 pre-hospital statistic, and also the 1 in 5 for in hospital. But the 1 in 10 especially is quite an old piece of literature. It's from 2006. So it's really pertinent for us to think about the fact that demographics have changed, who's being resuscitated has changed, and actually the presence of do not resuscitate forms and ReSPECT forms in the community have really decreased the number of older people who were at that time really unsuitable for CPR. It's really decreased. So it's really nice because we know these care plans are working and making sure that we're giving the right care to the right patients in the right setting. So ReSPECT forms are brilliant. We're going to put a picture of it here. So it's a purple form. You'll see them on the wards. They're up on a shelf. There's a big stack in some really nice purple Polly Pockets. And they're all about the wider discussions around patients. What are their wishes? You'll see a sliding scale on the sheet where patients can place themselves, and it helps us indicate whether they want full active treatment, nothing at all, or something in the middle. And so that really enables us to involve patients themselves. They're really easy for us to think they're just about resuscitation because there's a box for that. That's quite easy. Or we can write things like not for ITU, not for HDU on them. But actually, in the wider capacity of the patient, where that care plan might go next, is it going to travel with them for multiple admissions where they're changing? So we need to review them as well. But also things like, do they want to be readmitted? How many courses of antibiotics would they think about having? Are they someone who's in for recurrent chest infections and actually they're getting to a point where antibiotics are not solving the problem every time, and we need to be thinking about whether they're of benefit to them. Are they someone who, so someone maybe with advanced dementias, it might not be appropriate for them to have an anaesthetic and surgical fixture of a hip fracture, for instance? Would they want to come in if they had a fracture, but not if they had a pneumonia? Would they want to come in for sutures or that sort of fixable thing? But if it's not fully fixable and we bring them back to baseline, are they someone that would say, no, I don't want hospital admission? So it's about thinking about those things.
So the third point that we went through with the teams in the wards was the importance of not using one-sided leading language when we're having these conversations and trying to be as open and honest and transparent as we can. Because when we're discussing matters of life and death with patients and their families, it's crucial that we are honest with them. Because if they can't trust us as doctors and paramedics and nurses and other healthcare staff when we're talking about issues of such importance, it's hard to know who they can trust. So it's really, really important that we don't speak to them in such a way that exaggerates or bends the truth or overemphasizes certain points. Yes, we are the ones who make the medical decision on their behalf, and we decide what is in their best clinical interest. But in doing so, it's important that we don't force our opinions on them and silence them and prevent them from speaking up about their own fears and concerns and their own questions that they might have. Because in my time as a doctor, I've had several resus and advanced care planning discussions where I've come away thinking, oh, I could have done that so much better. And I've also been sat on wards where I've overheard people having these conversations over the phone, and I've thought, oh, I wouldn't have said that myself. Like, one example that springs to mind is when people justify their decision to make somebody not for resus by saying something like, you know, you wouldn't want us jumping on your chest and breaking your ribs and putting tubes down your throat, would you? And as I'm sat there listening to that, I'm thinking, no, of course they're going to say no to that. And I would probably say no to that if somebody had that conversation with me. So it's important that we don't just use that one sided language where we're giving them all the gory details so they have nowhere to go except back into a corner. It's important that it's a conversation, that it's a two-way thing. And as Georgie just mentioned there, that's what respect forms are for. It's to prevent it being so one sided and the patient almost feeling attacked by this overload of information. We want to hear what they would like, what types of care they feel they would and would not choose to have if they became unwell. And by having this two-way conversation, we can prevent it being one sided and leading in nature. So make it a conversation. Show empathy, give the patient time and space, and above all, be gentle and be honest.
I think also remembering that each one of us as health professionals has a responsibility to start these conversations and continue these conversations. So I think from my experience, clinicians pre-hospitally taking people in will often ask about respect forms and suggest them. So, and those in A&E will ask about them. And then the nurses in the wards will ask about them. We're all aware of them, but is anyone just starting that conversation? I think we can all presume you're not the first person. And if you are, make a good start at doing it, be empathetic. I think the main thing to remember with respect forms is that if this section signed DNA CPR is signed, it doesn't mean there's no active treatment. We still treat someone up until the point of cardiac arrest. It's at that point we're just not going to treat them. So I think that's really important to remember. It's just reiterating to patients and making sure in your starting conversations and when you're developing these forms with patients, really reiterating that we are still providing care. And because I think that's a big fear for people. They feel like they're giving away that trust and that trust in us as health professionals to provide care. They're worried that we're not going to and we're going to forget them, and that's absolutely not the case. And also reiterating that in the event that we decide that we're not going to do maybe something like antibiotics, we'll still give you medication to make you feel comfortable, and we'll still treat you with dignity and respect. Respect forms are bringing in a much more patient-centered and holistic view, and that we need to shift our thinking around these sorts of discussions to that holistic view, and making it as a starting point for referrals to palliative care. It's part of the process as well, I think, but that's really important.
Yeah, and that brings us on to the final point, which is all about how it's not just about communicating clear with the patients in front of us. There are other people that we must remember to talk to, and those people are the family members of the patient. It's not sufficient just to have a chat with the patient and move on. We must always, at the very least, make an effort to speak to the family members of that patient as soon as we possibly can. So, if you're a doctor who's on call and it's an evening shift and your job list is piling up, a conversation with that patient's family about advanced care planning might not be top of your agenda, but just a few minutes on the phone to a family member is all we're asking you to do. And it's not an optional extra, it's something that is very much expected of you. And to be honest, I think that's reasonable because imagine it was our parent or grandparent who was in the hospital, and this is somebody that we're heavily involved with the care of when they're at home. And then you go in and you visit your family member in the hospital a few days later, and you notice that behind the nursing station, their name is on a DNA CPR list, and nobody had told you anything about that. You'd be upset. And I think quite rightly so. So we must remember to keep family members in the loop. And it's not like we're putting pressure on the family members to make these decisions themselves. In fact, you should make that clear to them that that's not what we're doing. We just want to hear from them, hear their thoughts, hear their description, even just of how their family member is at home. And that information could inform the decision that we make about their care.
I also want to reiterate a point that I made when we had our Wednesday teaching, and I just want to say, show people what the form looks like, because the number of times I've been to patients' houses and said, have you got a ReSPECT form? And they say, no, dear, no, of course I don't. And you might find it folded up in that discharge meds bag. You'll find it in the envelope on the side that's marked with the doctor's name. People don't know what they are and what they look like, but they're a really important document. And when you show people, they're quite interested. They do want to know. It's very good to say that, yes, the GP should be doing it. Totally. It's part of someone's holistic long-term care plan. Absolutely. But trying to get hold of the GP at the moment, we know primary care is really overrun, and I know we're all busy, but we have that person in front of us and the GP doesn't. And that person might not find it easy to proactively access primary care, especially with the new teleconsultations first. So I think although primary care should do it and absolutely is ideally placed to do it, they're not always there. So I think we also have a place in acute care settings to do it as well.
Just before Georgie talked you through what you have to look forward to after the Christmas break in terms of our third topic of the week in the new year, I am just going to run through a few little suggestions that were given by our elderly care team in East Surrey Hospital about starting lines that could be used when you're trying to initiate these conversations. We are aiming to get you better at home, but sometimes people become more unwell despite active treatment. I would like to talk to you about what is important to you when it comes to your care. Have you ever thought about what treatments you want and don't want? I don't want to upset or offend you, but can we have a talk about your wishes if you become so sick that the treatment is no longer working and your heart or breathing stops? What do you understand by resuscitation? So, those are a few tips from our own team here about lines that you could try and incorporate into your discussions. But obviously, each situation will be unique, each person you're talking to will be unique. But those are possibly some little pointers that you can maybe use if you feel like you're lost for words at times. One last thing I just want to mention before I hand over to Georgie is a ReSPECT training website that is available for us all to use. And on the screen just now, I will put a QR code for this. It takes about 45 minutes to do. I did it just last week. It's really interactive. It's actually quite fun. There's lots of case studies, lots of quiz questions, and it really gives you a proper understanding of why ReSPECT forms were brought in, how they can be useful in these conversations, and how we can try and improve the way we have this communication with patients. Georgie.
So next time that we see you, which is going to be after the 12th of January, because that's when we're going to have teaching, we're going to be discussing delirium in our patient cohort, how we can address it, what the background of it is, and everything we need to know when we're caring for someone who might have a delirium. So the video for that will be out around the 21st of January as well, for those who can't attend teaching.
Brilliant. Yeah. Thank you for watching this video again. We really appreciate the fact that people are watching and engaging with it. And in the meantime, we hope you have a very happy Christmas and Happy New Year.